Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
We've talked about Lenacapavir a bunch of times in the last few months. Since it got approved, this is not going to be anything groundbreaking, but there was something new that happened, so I thought I'd share. These are my disclosures, just reminders that we got approval for Lenacapavir as prevention, as brand name Yes2Go, just a few months ago. And you can see the other medicines that are up there. And as with anything, we are probably going to talk or have some discussion about some of these medications used in different strategies that are not FDA approved for prevention. This is our disclaimer. So this is the reason for this talk today. This was the MMWR published just a few weeks ago. That is the PrEP panel's recommendations for the use of injectable lenacapavir. The last guidelines came out in 2021, even before injectable cabotegravir had been approved. But those recommendations spoke to cabotegravir and made recommendations for use of it under the eventual probability that cabotegravir was going to be approved by the U.S. Food and Drug Administration, which it was. However, due to current circumstances, the folks at the CDC, some of whom are no longer at CDC, decided that they would try to get out some recommendations for injectable lenacapavir, knowing that there was probably not going to be able to be the full process for the updated PrEP recommendations. So we have a specific recommendation from PrEP folks at CDC about using lenacapavir. So this is the citation for you to look at your leisure. This is a slide that we looked at the last talk I gave, which was also included some lenacapavir updates. And I just include it for links because the top one is going to have the package insert for the FDA approval, which we saw in June. And then the bottom is, again, the link for this MMWR article that I just shared with you. The bullet of the MMWR is this, which is that lenacapavir administered as a subcutaneous injection every 6 months is recommended as an HIV PrEP option in people weighing more than 77 pounds who could benefit from PrEP. It is a strong recommendation with high certainty of evidence. If you think of nothing else, this is what the MMWR said. But there are three things that I just wanted to bring to your attention because I haven't really talked about it quite in detail, and there are some differences from either the package insert or the previous 2021 PrEP recommendations. So we're going to go through some of these in more detail than the others. So the first is we're going to talk about how to assess someone for PrEP. And this is the language from the MMWR about considering PrEP in anyone, not just injectable PrEP. So we should consider use of PrEP in everyone, but in particular, people who are at higher risk for HIV. And they call out these groups: folks with STI, sexually transmitted infections, men who have sex with men, people who have sex partners who are HIV positive and the partner is not fully suppressed on HIV medicines, people who engage in transactional sex, people who are incarcerated, and people who share needles. And I call this out, again, because it differs from the 2021 guidelines, again, which haven't been updated, not likely to be updated anytime soon, which goes through this algorithm that you can see here. And while some of these categories of people that you would consider to be higher risk and strongly recommend and prescribe PrEP for, so the people with bacterial STIs in the past 6 months, there are others that were more strongly called out for in the 2021 guidelines, like folks with multiple sex partners who aren't in this recommendation. I think the sort of key point in this is that there are people who are at higher risk based on local epidemiology, and you probably know what your local epidemiology looks like. Across the country, maybe it is those folks listed in the MMWR, but as always, in these light green boxes from the CDC guidelines, if you go through and many people and the person's answer are all no, but they may want PrEP, there may be something that they're not telling you. There may be a reason to prescribe PrEP. So none of these are hard and fast. You can't prescribe for someone who doesn't meet these criteria. But I just want to point out that the MMWR is a little bit more prescriptive than the 2021 guidelines. Moving on to how to assess HIV infection. It's not different in any way that we want to make sure that someone is HIV negative before starting PrEP. None of the PrEP regimens are fully suppressive, and so someone can develop drug resistance if you start PrEP without assuring that they are HIV negative. And so before starting PrEP, we need to rule out HIV infection. The MMWR says same day point of care testing is okay, but do not use oral fluid. Again, oral fluid has a longer window period than finger stick point of care tests even. And so we really want to make sure that someone hasn't been recently infected if we're going to start PrEP. Interestingly, I don't know if folks are doing any HIV testing or had been doing any HIV testing using molecular testing laboratories, but there was a new HIV self-test just approved last week that is finger stick and not oral fluid. And so that may be something that I talk about in the future. But there are options for people to do home self-testing that aren't oral fluid, that maybe, again, if remote testing is part of your PrEP practice, that may be something that you want to look into. So as with everybody, we want to make sure that there is a laboratory-based antigen antibody test, and it should be done within the 7 days before the first injection of lenacapavir. And then there needs to also be an RNA test obtained on the day of initiation, or, again, this is from the MMWR, follow-up laboratory-based antigen antibody testing in 4 weeks if you don't have access to RNA testing. The MMWR comments that there's limited data suggesting there's protection after the second oral dose. So the way lenacapavir is started, as we've shared before, is that someone takes an oral dose injection on day 1 and then a second oral dose on day 2, so that someone would be protected at 24 hours. And then follow-up testing every 6 months and not 3 months, as had previously been recommended for various populations. Okay, so this is the MMWR. What I want to remind you about is that the package insert states that RNA test must be done before starting PrEP. And then we've talked before about what the package insert means, and is that a requirement? Does that establish the standard of care? And the answer is no. That it can be used to establish standard of care, but you are not obligated to follow the package insert. So when switching from oral PrEP or another injectable PrEP, they recommend only do a laboratory-based antigen antibody test, and again, not an RNA test, if someone has been adherent on their PrEP in the past. And then a note to remind people to confirm hepatitis B status, particularly in folks on oral PrEP, because as you all know, oral PrEP, both of the 2 combination pills are active against hepatitis B, and you don't want to stop treatment for hepatitis B. And so if you're switching their HIV pre-exposure prophylaxis, they may need another treatment for hepatitis B. I think this is my slide with the package insert. Again, that initiation of lenacapavir requires antigen antibody testing and RNA, but that follow-up testing only requires a test that's approved for the diagnosis of acute or primary HIV infection. And so the laboratory-based antigen and antibody test would be satisfactory for follow-up testing in lenacapavir. And then finally, I just want to call attention to some of the drug interactions that they're showing with lenacapavir. And I'm not going to go through all of these. But one of the things that I heard when people were starting to talk about using lenacapavir is that people were afraid about some of these possible interactions, particularly the use with benzodiazepines and steroids, that there are things that you have to do to monitor or to do increased doses. And so from the package insert, there's a comment specifically about CYP3A inducers and differentiating between strong and moderate, and when you can start the lenacapavir and when you can start the inducers, and that the folks who are taking the strong CYP3A inducers actually need a double dose. So hopefully it's not, a couple days apart, but they may need every 3-month dosing as opposed to every 6-month dosing. So they're going to get twice the amount of lenacapavir. For folks who are on moderate CYP3A inducers, you can start them at any time related to the len, and then they will need half dose, so just one of the 2 injections, again, every 6 months. So they're going to still need to come in 4 times as opposed to twice. And then for folks who are already on inducers, there are actually no dosing recommendations. And just to share, there's no dose adjustments in renal impairment. There's no dose adjustment with mild to moderate liver disease. And then caution should be exercise of use of len in the elderly. This is not my age, anyone over 65, due to the concomitant illnesses and medications. Not mine, not my words. And then finally, the MMWR comments about minimizing injection site reactions. Injection site reactions are the most common side effect associated with injectable PrEP and are often the reason why people discontinue. And they recommend making sure to use a 90-degree angle or at least no less than 45. So 45 to 90-degree angle. And really the goal is to avoid intradermal injections. And they comment that ice packs and topical or oral analgesics may decrease those injection site reactions. So for injectable cabotegravir, the window is, once you get to every 2-month injections, the window is plus or minus 1 week. For injectable lenacapavir, it is plus or minus 2 weeks. The recommendation would, of course, be to try to schedule your initial visit during the early part of that, so not to schedule right up to the end, so that if someone misses or reschedules, that you have the opportunity to bring them back still within their window. And I thought this was interesting that if you miss your injection dose, the recommendation is to prescribe a single oral dose once a week, and you can do that for up to 6 months. If you go longer than 6 months, you basically restart dosing again. That was my last slide, and I want to thank you.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.